Yeah, we can go live.
Okay, thank you, Moinesh.
Yeah.
Good morning, everyone. I, Mayur Revalkar, on behalf of Mumbai branch of Indian Association of Physiotherapists, welcome all of you for the continuous physiotherapy education series program on the topic of role of physiotherapy in sexual health. It takes me great pleasure in introducing our chairperson for today. We have with us Dr. Nilima Bedekar as a chairperson to chair this session. Madam has done her BSc PT from GMC Nagpur, and she has done her MSc from UK. And also, she is a PhD holder from Pune University. She is currently working as professor and head of department at on the Department of Musculoskeletal Physiotherapy at Sancheti Institute College of Physiotherapy. She is former academic council member and chairman UGBOS at MUHS Nashik. She has her expertise in women's health, yoga, and electrotherapy. And she has many publications, national and international, in international journals to her credit. We welcome you, ma'am, and thank you for accepting our invitation. Over to you, ma'am.
Good morning, everyone. And we welcome our speaker for the day and waiting to hear from her. But it gives me an immense pleasure to welcome Dr. Darshana from USA. I have tried to make her introduction as brief as possible, but still we have to speak on so many things. She's done her Bachelor of Physiotherapy from TNMC at MUHS, and then she has done her Master of Science in Musculoskeletal Physiotherapy from University of Pittsburgh, USA. She has done Doctoral of Physiotherapy from University of Montana. Currently, she is a PhD scholar at Texas Women's University at USA. So with this background, she has so many certifications, including the McKenzie Institute, MDT, the board certified physical therapy in orthopedics, physical therapy, and board certified clinical specialist in women's health. She has certificate of achievement in obstetric physical therapy by Academy of Pelvic Health by APTA. She has various clinical expertise since 2014. Till now, she is Action Reaction Physical Therapy, Seattle, USA. She has established women's health practice, and she has spearheaded women's health program in orthopedic physical therapy for women's health at Executive Park Physical Therapy workers. She has worked as clinical instructor for DPT students at New York Medical College. She is also mentor for APTA clinical residency at orthopedic physical therapy and was teaching assistant at New York Medical College. Also class volunteer for Penny Simkin Birth Classes 2020. She's a founder and primary educator, pelvic physiotherapy, educational platform for physiotherapists in India. It's remarkable, I feel, being the founder of Pelvic PT Gyan. She has to her credit and spoken publicly at various conferences, and a podcast she's launched in 2020 on Pelvic Gyan. It's tremendous. She has been keynote speaker at NW Dollar Conference in 2019, at American Association of Sexuality Educators and Counselors of Pelvic Physiotherapy. Currently also as a guest speaker at various women's health groups worldwide, I believe so. She's volunteer experience at Academy of Pelvic Health at APTA. She's involved in professional development courses in women's health, various areas of women's health. She's a member of American Physical Therapy Association and member of section of women's health of American Physical Therapy Association. So great resource person, Dr. Darshana. We welcome you again, and you could start addressing the audience, and we will be really awaiting to know about this area where it is very less discussed.
Thank you, ma'am.
So,
Thank you for the kind and
yes,
generous introduction.
welcome.
I'm going to start sharing my screen. If somebody can give me a thumbs up when they can see it, that'd be great. Can you see it?
Yes. It's visible.
All right, everybody. Thank you so much, IIP Mumbai branch, for organizing this. And thank you for that introduction, Nilima ma'am. You already heard enough about me, but I wanted to thank everybody for trying to spend their Sunday morning with me. And I'm very excited about this webinar, particularly because I did a few of them this month, and this is my last one of the month. But as you all probably already know, that pelvic floor physical therapy is a very underserved area of physical therapy in general. But even within pelvic floor, sexual health is something that we don't really talk about, because half of the time it's a taboo subject, and other half of the time, honestly, we don't know enough. But this lecture is kind of like a little bit of introduction or a teaser as to what is the role of physical therapy in sexual health. So I hope you guys walk away with some important information today. So before we get into sexual health, I think it might be important to just take a step back and look at what health means, right? Health means different things to different people. Health for somebody might just mean, if I don't have diabetes or blood pressure, I'm healthy. But for somebody else, health might mean I need to have six-pack abs and be able to run 6 miles for me to feel healthy. So health is a very subjective concept. And that's not any different when you're talking about physical health, mental health, or sexual health. For obvious reasons, sexual health is a loaded topic that is shaped by culture, that is shaped by what beliefs you heard growing up, that is shaped by different factors that have nothing to do with organs and muscles. And that's why when we're thinking about the concept of sexual health, there is that added layer of understanding what does health mean for the person in front of you, and what are the determinants for health for that person in front of you. We talked about pelvic health being an underserved area, and for those of you in the audience who don't know what pelvic health is, generally it is pelvic health generally deals with problems related to pee, poo, and pleasure. For today's lecture, we're talking mainly about the pleasure aspect, the sexual health part. So if you are a practicing pelvic floor clinician, why do you need to know about sexual health? That's because when people have pelvic floor dysfunction, close to 50% of them can have sexual dysfunction. So if you treat pelvic floor problems, 50% of your people have sexual dysfunction, whether you may know that or you may not know that, but they do have those problems. So here are some numbers. When people have incontinence, when people have prolapse, when people have coccyx pain, or when people have fecal incontinence, for understandable reason, they don't necessarily feel comfortable with their sexuality. So what we notice is there are people who will avoid, almost up to 22% women on a survey study were found to avoid participating in sex because they're afraid of leakage. They're not leaking on sex, they're just afraid of leaking. So that goes to show us that pelvic floor dysfunction directly and sometimes indirectly, just coming from lack of knowledge and fear, impacts sexual function. So if you're a pelvic health clinician, it is really important that you understand how these muscles affect sexual health. Now, let's say you're not a pelvic health clinician. Then why do you need to know about this? If you're not a pelvic health clinician, what we do know that low back pain, hip pain, SI joint pain, coccyx pain, all the conditions are associated with pelvic floor dysfunction. And we just learned pelvic floor dysfunction is associated with sexual dysfunction. So what we are looking at are numbers that tell you that even if you're not a pelvic health clinician, these are problems that your patients might be facing, even though you're not aware of it. So why should you ask your patients about their sexual dysfunction? Because you may not be able to treat it. You might not consider yourself a clinician who wants to treat sexual dysfunction, but then why is it important as a PT, nonetheless, to screen for sexual dysfunction? That's because patients who have pain with sex, close to 90% of the time muscles are a problem for these people. And who are the experts of muscles? Physios. So if this is a muscular problem, and if we are asking why should we screen for sexual dysfunction, I think the right question is why shouldn't we? Because if 90% of the times sexual pain is related to muscular problems, and now I want you to take a step back and hear what I said. I'm not saying sexual dysfunction 90% of the time is muscles. That's not what I'm saying. I'm saying sexual pain 90% of the time could be muscular contribution. So this goes to show us that physical therapy not only has a role in sexual health when it comes to pain, but it has a very important role in improving sexual health, particularly if pain is involved. So before we get into the anatomy and nerve supply and all of the boring stuff, let's start with physiology for once, because, let's talk about sex. This probably is a sentence we don't hear a lot. So let's do that today. Simplifying, sexual function can be broken down into desire, arousal, and orgasm. Desire is something that starts in the brain. Brain is the boss. Brain is where sexual desire lives and originates. So if brain is the boss, we ought to think what happens with people with brain injuries. What happens with people who don't have an injury in the sense of a stroke or Parkinson, but more like trauma, stress, PTSD? What will happen to sexual desire for this person? What will happen to sexual desire of a new mother who's not necessarily traumatized, but just is overwhelmed? Second is the effect of autonomic nervous system. Sympathetic nervous system, parasympathetic nervous system, right? Parasympathetic nervous system is where we rest and digest. So we do need parasympathetic nervous system if we want to digest our food, if we want to have good bladder control, and if we want to have pleasure, meaning no pain with sex and good orgasms. If somebody has a sympathetic nervous system overdrive because they have chronic pain, because they have PTSD, because they have injury, because they had surgery, or because they have any other nervous system problem, desire and arousal are going to be affected. So it's really important to understand how brain and the nervous system plays into the desire and arousal part. These are the things that are more pathologies. But what about psychology? If you grow up in a culture where you only hear negative things around sex, if sex is a taboo subject, if sexuality is looked at as something that is bad or shameful, if a woman's worth is kind of attached to her virginity, it's really easy to understand why the brain would not want sex, because the brain would want to think about it as something bad and something that is impure and something that you would get chastised for, not just you, your entire family, right? So brain is where it starts. And that's why it's really important if you're talking with a person with sexual dysfunction or vaginismus or penetrative pain, it's important to understand where is their belief system. If they think sex is a bad thing, you could be stretching their levator ani all you want. You're not going to get anywhere unless we deal with some of those belief systems. Likewise, if somebody is having a whole lot of PTSD and trauma, unless they're seeing a counselor for that trauma, you're not necessarily going to get anywhere with their pain. Next is arousal. Like we talked about, desire happens in the brain. Arousal is essentially your brain telling your downstairs that you're aroused. So what typically happens is just increased blood flow. What you're looking on the right side is a penis and a clitoris, just to show you embryonically, they sort of develop from the same tissue and they function in a very similar fashion. When the brain has sexual desire and when the brain feels like you're safe, the brain will then generate sexual arousal, which includes the uterus squeezing and creating some mucus, lubrication, improved blood flow, improved heart rate, sweaty palms, increased blood pressure, all of the things that are essentially under the category of vasocongestion in the genital area, which is commonly referred to as being turned on, right? That is genital arousal. What we ought to understand here is when there is genital arousal in a penis owner, You can see it, it's visible, it's an erection because there is improved blood supply and engorgement. But we don't really know how this works in a vulva owner. Arousal in a penis is the same as arousal in a vagina. The only difference is vaginal wall, which is a tube, becomes engorged, which is vasocongestion, same as the penis, but it becomes deeper and bigger. So you can't really see it. So in other words, penis and vagina do the same thing. Penis just does it outside, vagina does it inside. And if arousal is missing, if the vaginal tissue has not expanded, anything that is forcefully put inside the vagina is going to cause pain. So when you're talking about pain, when you're talking about people with penetrative pain, it's important to understand what goes into arousal and how is that factoring into their pain. A simple example would be estrogen. How will blood flow increase in the vulva? We will need estrogen to improve blood flow in the vulva. So when you're thinking about postmenopausal women or women who have had hysterectomies where there's no uterus to contract and create that mucus, or no estrogen where they are getting the vasocongestion or increased blood flow, vaginal dilation isn't happening. So the pain may not necessarily be because of tight muscles, but because of tissue that requires estrogen. Here's where genital arousal becomes important to understand. This is just a visual schematic to see, just to get you oriented. On the left side, what you're seeing is the small hole is the pee hole, and this is the vagina hole. You see that tube, that's the vagina, that's the one that expands. But what I really wanted you to see is this big structure that you see around, that's the clitoris. A lot of times clitoris is thought to be this lentil-shaped bulb that you see on the top. That's just the bulb. But this entire structure is the clitoris. What do you think is this? These are pelvic floor muscles that are under the labia. So that even structurally makes sense why arousal, orgasm, and sex would just be tied into pelvic floor muscle function. And the last part, we talked about desire, we talked about arousal, now we're talking about orgasm. Orgasms are, we have more myths around it than actually knowledge around it. What we do know for a fact is there is no standard definition of an orgasm. There is no standard definition for any male or female sex. What we do know is at a muscular level, it's repetitive contractions of the pelvic floor muscle. Right. What we do know that there are sympathetic and parasympathetic nervous system changes that happen with orgasms. What we do know is it is not only associated with rhythmic contractions of the pelvic muscle, but it is also associated with rhythmic contractions of all the sphincters, like your bladder, neck, and anus. Orgasm also involves rhythmic contraction of the vaginal wall. So here's where it becomes important. If you're treating a male patient with interstitial cystitis or IBS who has any issues with anal sphincter or bladder sphincters, they're likely to have pain with erection and pain with ejaculation. If you're treating a woman who has had atrophic vaginitis or cancer-related chemotherapy and there's scarring in the vagina, you're going to have pain with orgasms. So that's where it becomes important as to what structure and what function are you tying with it. Now that we talked about function, we are going to talk about structure and look at the anatomy. And I do want to put a little disclaimer. I know I have put in some silly images, but that's because this topic is so heavy that the last thing we need is a serious face. So trying to find some humor in a very loaded topic. Again, giving a little overview for those of you who are not familiar with pelvic floor muscle terminologies. If you look down in your pelvis, this is a muscular view that you will have. If you have a vagina, you're going to find 3 holes. If you have a penis, you're going to find 2 holes. Generally speaking, these muscles are like a muscular underwear. And when these muscles squeezes, all the holes closed. And when these muscles relax, all the holes open. Now, this is just a really short lecture, so we don't have time to go into individuals of every muscle, which is really important to understand with function, but I do have some overview planned for you. So let's get to that. What you're looking at is on the right side is a female pelvis, on the right side is a male pelvis, and the muscles are really the same. They're just kind of arranged differently. So on the right side, what you're seeing, this triangle shaped muscle, that's the urogenital triangle. The muscle that makes the base of the triangle usually associated with allowing the opening of the introitus. Introitus is this, the opening of the vagina. When is this muscle most involved? Birth-related tears. So you can see how pain with sex after giving birth is usually associated with this muscle. The second muscle that you see around the labia is the one that allows the dilation of the vaginal opening and allows penetration. This is the same muscle that contributes to rhythmic vaginal wall during orgasms. And the muscle that makes the sides of the triangle, sort of like this, right? That the muscle that compresses the clitoris and contributes to congestion of the clitoral hood and orgasm. Same functions in the penis owner. This is the superficial transverse perineus, and these are the same other two muscles. Their job in a penis are contracting to block blood flow. Arousal will get a lot of blood flowing to the penis. The job of the pelvic muscles is to compress the veins and maintain erection. So the job of pelvic floor muscle in a man is allowing erection, maintaining erection, and then rhythmic contractions that result in ejaculation. So same functions, just arranged differently. Here's a little more schematic view. These are the muscles we were talking about. You can kind of appreciate where the clitoris is going to be. That is the labia, and this is the muscle. So if somebody had a surgery, if somebody had a really bad birth and had a lot of tearing in all of these muscles, you can appreciate how that would factor into their pain with sex. Let's say somebody had pubic symphysis pain. It's very common in pregnancy, symphysis pubis, right? It's right here. What attaches to pubic symphysis? All of the layer 1 pelvic muscles. So pubic symphysis pain, very commonly associated with painful penetration, right? And lastly, look at this tailbone. Where are all these muscles attaching? Tailbone. So if somebody had coccyx pain, tailbone pain, fell and broke their tailbone, or had a birth injury, or fell off of a horse, tailbone is going to be injured, and it can contribute to pelvic floor dysfunction that results in painful sex. Same muscles in a male anatomy. You're looking at the superficial transverse perineus. I put this picture just to show you where to find these muscles in a male patient. This is the shaft of the penis for reference, and these will be ischial tuberosities, right? This is for the nerds in the group. If you need origin, insertion, function, nerve supply, here you go. So before we go on to cases and fun stuff, oversimplification. Pelvic floor muscles, or the muscular underwear inside the body, generally needs to relax and allow the holes to open for pain-free penetration. And this is me oversimplifying it. The muscular underwear needs to be able to squeeze and have strength in order to have mechanoreceptors that can be stimulated for erection and orgasm, right? So what are some of the common things that we treat in pelvic floor PT under the category of sexual dysfunction? You're seeing the list. Obviously, I cannot cover all of these today, so we're going to just touch base on a couple of those, but this is a list of diagnoses that you treat as a PT when you're working in sexual health. Those were the diagnoses, like for example, vaginismus or dyspareunia is such an umbrella term. Anybody who has pain with penetration is dyspareunia, but that could be because of gynecological causes like endometriosis, or it can be because of urological causes like repeated yeast infections and UTIs, or it could be a neurological reason like pudendal neuralgia, or it could be a GI system reason like IBS. Or it could be a purely musculoskeletal reason, like they shattered their tailbone, right? So these are the different deeper root causes as to why somebody might develop dyspareunia or painful sex. So the point I want you to take away from this slide is painful sex is not a diagnosis, it's a symptom. And unless we find out what's the root cause diagnosis, we're not really effective in treating it. So here's all the things that could be contributing to the diagnosis that we treat. So sometimes the issue is in the tissue, like menopause, that can cause vaginal tissue atrophy, or birth-related tears, like it can cause scar in the pelvic muscle, or it could be related to endometriosis and adhesions in the vaginal and rectovaginal fascia, or it could be musculoskeletal causes that we talked about. But sometimes the issue is not in the tissue, like the things that you see on the right side. Maybe the person is in an abusive marriage. Maybe they are stressed. Maybe they have a history of rape or sexual abuse where their central nervous system is undergoing a lot of trauma and their sympathetic nervous system is on overdrive. And that person is not going to have sexual desire, arousal, or pleasure, right? Sometimes it has everything to do with cultural and religious influences, where people view sex as not only a unspoken thing, but almost a bad thing. They look at it as something that they don't want to talk about, don't want to deal with. How do you think this person is going to behave with their partner just because they got married, right? So a lot of times there are issues that have nothing to do with the tissue that are causing pain with sex. A good example would be of trauma is adverse childhood experiences. I once treated a patient who had a lot of like a congenital kidney problem and needed a lot of procedures as a child that required repeated catheterization. Can you imagine putting a catheter in a little child? Everybody was holding her down and inserting catheters. And yes, she needed that. She had a kidney problem. But can you imagine the amount of trauma that child carried away? It's medical trauma. It wasn't sexual abuse, but it was still trauma. And as a result, their brain remembered that and their brain looked at any penetration as a potential threat, right? So we sometimes have to look past things that are in the neighborhood. For those of you who work in chronic pain field, you know that pain doesn't necessarily tell us anything about the status of that tissue, and we have to look past it, particularly in people with chronic pain. So like I said, I cannot cover all the things that go in sexual dysfunction, but the first one I picked is genital pelvic pain penetration disorder, because this is the most common thing we treat in pelvic floor PT. Dyspareunia and vaginismus are sort of combined together under this category with DSM-5. So what we do know is any pain during, before, after sexual intercourse is called dyspareunia. Vaginismus is when there is vaginal spasm involved with it. So for argument's sake, vaginismus is a kind of dyspareunia, right? But it's really hard to distinguish. And that's why the DSM categories are now genital pelvic pain, penetration disorders, like one umbrella term, including both of those, right? In vaginismus, what we see is there's an involuntary spasm. That spasm makes it painful to tolerate penetration. When you do decide to power through it and go through it, your brain remembers the pain, so you start to develop fear of penetration. As a result of that fear, next time, with an anticipated penetration, you start to spasm. And now you're stuck in this vicious cycle where it's hard to tell whether the pain happens first or the spasm happens first. Vaginismus can be lifelong vaginismus, meaning a person cannot put anything inside their vagina for as long as they remember, whether that is a speculum at a gynecologist or a tampon or partnered intercourse. Secondary vaginismus is somebody has had pain-free penetrative sex and now an event happened, and ever since that they cannot tolerate penetrative sex. A good example would be childbirth. A person who was having pain-free sex, had a baby, had really bad tearing, and now their vagina goes into spasm every time they attempt penetration. That would be an example of secondary vaginismus. Different causes, different treatments, but that's just two kinds of vaginismus. But like I said, going forward, DSM-5 category doesn't distinguish between vaginismus, dyspareunia, all of that. I put this quote because a lot of times women with vaginismus are told that it's all in their head. All they need to do is have a glass of wine, relax a little bit. And in India, a lot of times they're told to do this for their husbands, and just to look at the bigger picture and just to look at their role as a wife. women are often threatened as in vaginismus diagnosis that if they don't give their husbands sex, they are going to be out of that marriage and their husband's going to be finding somebody else. We just talked about how sympathetic nervous system factors into all of this. What is that kind of stress going to do to that person? Right. So it's important to know that even though vaginismus is not a psychological, it's a physio-psychological issue, which means there is something wrong with the muscles. It is very often that that issue can get to your head just because of all these cultural narratives that are associated with it. So it's important to reinforce to your patients that this is not in your head. It's a real issue. It's a real diagnosis, but understandably, it can get to your head. Why am I talking about vaginismus so much? That's because my PhD research focus is vaginismus and genital pelvic pain. Why? That's because when you look at the numbers, penetrative pain in the US is about 17%. But when you look across the world, here are some numbers on this slide if you are interested in numbers. But when you look across the world, parts of the world that are conservative and follow conservative religions, such as Catholic people, Islam, and Hinduism, there are very conservative thoughts around sexuality, and that religious narrative around female sexuality has been found to be increasingly associated with penetrative pain. So when you look at the numbers in the US, 17%, in Tehran, they're 40%. And in India, they're close to 65%. So 65% of women have penetrative pain. And this is a fairly recent study done in South India. But what was interesting in that study is close to 80% women who had pain, 80% of them did not feel comfortable reporting that to their partners. So if they don't feel comfortable reporting that to their partner, you can only imagine how they will report it to their doctors, much less physical therapists, right? But that's sort of why I'm studying this as a PhD topic, to understand why are Indian women at such a higher risk. And that's why I'm talking about this topic today, because you are making a difference when you are addressing that in your patients. So, bigger picture, we have biological reasons why somebody would have pain with sex. We talked about the issues in the tissue. Psychological reasons, we just talked about the social and cultural factors. So we have to look at the whole picture, not just the medical diagnosis that comes along with vaginismus. I tried to put a video of a vaginismus patient, but we were having some technical issues. So now I had to back up a video from a different patient, but hopefully you enjoy that. I'm gonna need somebody to turn their video on and give me a thumbs up if you can hear.
I came to pelvic PT initially because I'd had some difficulty with healing because the doctors had taken my stitches out at 3 weeks postpartum because it was causing some inflammation. And that pretty much led to having 7 subsequent procedures to fix and heal the area that was dealing with massive granulation tissue. It was incredibly painful. I peed standing up for 7 months, didn't touch the area, didn't look at it, ignored it. I had major mind-body dissociation happening. Couldn't have sex with my husband the whole time. So I was referred then at that point to just a traditional physical therapist. It was a man who specialized in knee therapy, and he just told me to suck in and pretend I had a marble in there and hold it in place and do that a bunch. It was not helpful. So at that point I went back to my OB. I came to pelvic PT. So at that point, I went back to my OB-GYN and I said, this is not working. And she referred me to Darshana and told me about pelvic floor therapy. So we did our entire interaction online via telehealth because it was during the pandemic. This was in July 2020. And I didn't really know exactly what it was. I thought it was just going to be physical exercises, maybe some massage of the, perineal area. And it ended up being a lot more than that. Now I know that pelvic floor therapy is so much more than Kegels. It's a holistic approach to healing. It looks at the biological, social, and psychological factors that play into your healing process. And for me, there were so many issues across all three of those facets that required attention. Now I know that pelvic floor therapy is. On the biological side, I was doing physical exercises that were strengthening my core and my back and the areas surrounding the pelvic floor area that helped to strengthen that and help stretch and create flexibility, given my estrogen was still really, really low because I was breastfeeding. But Darshana worked with me and worked through that. It was also about like logging bathroom trips and working on my diet, increasing fiber intake, hydrating, and then using all that data-informed like journaling to make observations and then cater to treatment plan for me. On the biological side, on the psychological side, pelvic floor therapy helped me rewire my brain's relationship with my bladder, because of the trauma I'd had in that area. I was going to the bathroom very frequently, my pelvic floor was very weak, and so I didn't have a lot of control, and I was constantly afraid of going out of the house and being away from bathrooms. So I just never left my house, and it was really debilitating. So psychologically, she helped me become more aware of the problems that were happening, or Darshana did, and work through that by slowly titrating and controlling when I was going to the bathroom and becoming aware and having kind of mantras that you say to remind yourself that you're okay. On the psychological, additionally, on the psychological side, through pelvic floor therapy, I was recommended some reading that helped me to transform my relationship with sexuality, to kind of break down stigmas and things I had been taught growing up about sex, and made me feel more free and less broken, and have a different relationship with my husband in that way. And it was really, really positive, and our sex life is better than it's ever been. Additionally, on the social side, pelvic floor therapy encouraged me to bring my husband into the process, to help me with the healing, to be a sounding board, to be a support person as I worked through this. And it was really healing for both of us, and it also gave him more awareness of what I was going through, which then made me feel better supported by him. And part of this healing was because I wanted to be able to return to, not just return, but like improve our intimacy from what it was even before having a baby. And I'm really, really grateful to pelvic floor therapy for helping transform, rewire, heal all the good things that it's done for me.
So here are two examples that I wanted to share today. This first patient was a 36-year-old Indian man, right, facing rectal pain. What we want to understand here is sometimes people will have symptoms that are just pain, and they have sexual dysfunction going with it that they don't feel comfortable reporting. This patient's history was a history of bladder cancer. He's a young bladder cancer survivor who had radiation therapy as a part of the cancer treatment, and that resulted in some scarring and blood flow issues around all of the genital area. And as a result, the person had not only bladder issues, but also painful erection and constipation. I treat male pelvic floor patients via telehealth. So there was no manual therapy involved, but just with addressing some of the pelvic floor issues, this person was able to have pain-free erections. So if you have any patient intake where you understand patient's medical history, bladder cancer or prostate issues are very often associated with painful sexual function. So that's just a case to understand why it's important to screen that in men and not just in women, right? Interstitial cystitis is another example. While it's more common, 8 times more common in women, men also do have interstitial cystitis, and more often than not, it is associated with sexual dysfunction along with bladder symptoms. This is a second case, and I tried to pick cases that are sort of out of the normal so you kind of see a bigger picture here. This person had a very complicated birth that finally resulted in a cesarean delivery. A lot of times we think painful sex is associated with tear in the vagina due to vaginal birth, but pregnancy is also hard work carrying that baby. On top of it, a cesarean delivery is abdominal muscle injury, right? So not always penetrative pain is associated with vaginal tear. In postpartum folks, it could sometimes be even with a planned cesarean. So just because somebody has a cesarean, don't rule that out, that pregnancy is the cause, sometimes not necessarily the mode of delivery, right? But what were the psychosocial parameters in this person's pelvic pain? This person had a lot of birth trauma. They really wanted to have a vaginal birth and ended up having a cesarean. The most common narrative mothers are told, well, you're safe, the baby's safe, that's all matters. But for that mother, maybe the mode of delivery was important. It was very stressful for her to raise a baby with a lot of cultural influences from lactation related beliefs, postpartum beliefs, how to raise the baby related beliefs. And on top of that, perinatal mood disorders. All of that was giving this person a lot of anxiety, causing a lot of overactive pelvic muscles, which was then causing penetrative pain. So there was no vaginal tear, and yet pregnancy was only a little bit of a contributor. The bigger contribution was coming from postpartum social struggles, from things like lactation issues, things like mothers and mother-in-laws interfering with the postpartum decisions, and things like perinatal mood disorder. I tried to cover some specialty populations in this just to help you understand even broader scope of pelvic floor in certain populations. The first one is aging. The average age people live these days is very different than what it was 100 years ago. And as a result, the functions of a 50-year-old person are different than what they used to be. What we do know is postmenopausal women, back in the day, people after menopause were usually retired. Now, postmenopausal women are actively in the workforce and living their life and exploring new relationships. And there is a very well understood category of symptoms called genitourinary syndrome of menopause, which involves bladder symptoms, vaginal dryness, and painful sex. All out of these three, the two can be treated with pelvic floor physical therapy, and we just don't ask those right questions. So it's important as any kind of provider to look at the patient in front of you. And if that person has had menopause, it is important to screen for genitourinary syndrome of menopause, whether you're a primary care physician or a physical therapist, because more likely they will have bladder symptoms to go with it. Second specialty population is along the spectrum of gender. Just for the sake of clarity on definitions, sex is when a baby is born, the doctor looks between the legs. If it's a penis, it's a boy. If it's a vulva, it's a girl. That's sex. Sex is what people associate with genitals. Gender is what we associate with a certain genital. If somebody has a penis, they wear shirts and pants and act like a boy. If somebody has a vagina, they wear dresses and saris and act like a girl. Gender is a social construct. Gender identity is what a person feels like within themselves. I'm sure all of you can appreciate that when you're working in the area of sexual health, understanding these concepts and providing inclusive care is very important. And a lot of times when I teach in India, I get emails later on that ye sab India mein nahi hota hai. Not true. And second, it really comes down to, if you want to be an inclusive clinician, your beliefs are not as important as your patient's beliefs. So I would encourage you to look into these terms. Obviously, this is outside the scope of today's class, given the time restrictions, but I did want to put that information out there. I do treat a lot of transgender patients and patients who've had sexual reassignment surgeries, and it is very common to have sexual dysfunction and body dysphoria, and physical therapists are the biggest part of their care team, and we have increasing level of importance of role in gender reassignment surgeries. The patient heard the clinician, because from being a good clinician, So the only assumption we should be making is the patient in front of you has some sort of trauma. So whenever you are using language around gender or sex, it is important to practice that within yourself. It is important to not giggle. It is important to not feel awkward, so you can provide the best care for your patients. If you, like I said, today we didn't have enough time, but if you're more interested in learning about this, I do have a class that is going to be completely virtual, and that is going to help you become a clinician who can treat all pelvic floor dysfunctions remotely without doing any vaginal or rectal exams if you don't want to. So if you're intrigued and interested, here's a link for it. Sign up. The last day to register is February 1st. Here's where you can find it, and Instagram is the best place to connect with me. Last piece, what to expect in physical therapy treatments of patients who have these sexual dysfunction. You'll basically talk about all things pee, poo, and pleasure. Why? Because we just learned that bladder and bowel dysfunctions are associated with sexual dysfunction. A pelvic floor PT is a musculoskeletal PT essentially by default, right? So there is going to be mobility assessment. You're going to look at the hip, you're going to look at the lower back, and the added layer is you're going to do a pelvic muscle examination. You are going to do pelvic floor examination either externally or internally, depending on your comfort level and your patient's comfort level. And with telehealth, I don't even do that. I teach patients how to do their self pelvic floor muscle exam. And you just heard in that review how effective that is. So muscle evaluations can be done so many different ways, but they are important. So figure out which one works for you. Patient interview, like any other history taking, is going to ask a whole lot of things, but the other things that you will ask about are bladder habits, bowel habits. You will ask about sexual history, and you will ask basic questions about their mental health and physical health, because we saw how overall health impacts sexual health. So some of the questions that may not seem so intuitive to ask is, what does sex mean to you? Because we make an assumption that penis in vagina is sex, but there are many different definitions of sex for different people. And again, making assumptions hurts you and hurts your patients. Don't make assumptions, just ask the patient, and they're really willing to give information, because most of these patients are struggling. They don't know where to ask for help. It's a very private problem. So if you ask the right questions, they are so willing to provide you the information that they need. Interventions. When somebody has sexual dysfunctions, their intervention really depends on what their cause is. So there is going to be a team approach. It's always going to be a multidisciplinary approach to sexual dysfunction, right? Because you have to treat the root cause. So it's important to find your right team. What evidence shows us is the best outcomes are when there is a physician, a physical therapist, and a sex therapist involved, right? Medical interventions, they can be ranging from a medicine to Botox injections in the vagina to a surgery in their spine or to interstim in their sacral plexus. So variety of medical interventions depending on what's going on with that person. Variety of topical medicines to just decrease pain and decrease sensitivity of that area. Physical therapy treatment plan, in one word, is muscular rehabilitation. So there is no protocol for sexual pain. There's no protocol for anything. But the interventions that you use really are dictated by what is that person's muscular status. This is me over generalizing it, but usually it comes down to treating overactive pelvic muscles. Teamwork makes the dream work. What I mean by that is, if you're a pelvic health PT, find a sex therapist, find a physician or a gynecologist who works with sexual pain. If you're a physical therapist who doesn't feel comfortable doing pelvic health, find a pelvic PT in your area so you can collaborate and offer the best care for your patients, because too often our profession kind of holds ourselves back because we fight amongst each other and there's enough to go around. So not only collaborating with people outside physical therapy, it's important to collaborate with your colleagues within physical therapy. My orthopedic PTs refer to me all the time, and if I find a hip issue, I refer out all the time. So the more you collaborate, the more we take our profession forward. These are some of the standardized outcome surveys that we use. This is the literature that went into this presentation. Thank you very much for listening the whole thing. I tried to keep it crispy and interesting. I am here for questions, but I do want to thank the entire organizing committee for doing all of this work, communicating between the topic and the time zones and all of that. So thank you very much for inviting me and hosting this. For those of you who want to reach out to me, Instagram is the fastest way to get a hold of me. Here's the link for the foundation class, and feel free to ask for my email from the organizers, and email is another way to reach out to me. I'm going to stop screen share in case somebody has questions. I have an active podcast on YouTube that has an episode about vaginismus in case somebody wanted to understand more about vaginismus.
Thank you, Darshana. Thank you for the session. May I request Nilima ma'am to chair the session?
Yes, sure. So, Darshana, really
Yes.
a great talk, and you have taken up so many issues which you have highlighted so well that it's very important to know about the history and to know about, we talk about pelvic floor, but the questions to ask about sexual function are so important, and you have brought out all the figures which are so very closely related. That has really made it very interesting. And we understand how important the psychology of the patient will be. And we need to, I feel, we need to propagate ourselves because they don't come forward with such problems. So that's very, very important. I feel we have to be associated more with the urogynecologist. There are either gynecologists or urologists. So I feel I work with urogynecologists, which makes things a little more easier. And we need to have specialization into this area. I feel we are still lacking in specialization in this area. But even the musculoskeletal therapist can be trained for pelvic floor. You have said it, the muscles is great. Yeah, that's very, very important. And holistic approach which you have brought in. So we have to really see whether they are receiving the medications and in total, because sometimes we can't work alone, and that's very important to collaborate. I find we must reach people and identify these problems. We have to make living graceful, and the life is so precious. And you have brought in the issues of men too. That's really great, I feel. So we have to handle this from adolescent age. Getting fit and getting fit before getting pregnant. We all know that, but we're not able to still reach to people, and getting through women through the childbearing age and beyond. So I feel women are living longer, and they also expect that physiotherapists now many of them know that physiotherapists can help. So how to reach, we really have to address, and I feel Mumbai IP branch has taken this issue. So more and more women will come to us, and we will refer appropriate specialists. So that's also very important that we refer to someone and work in collaboration. A great talk. So only one question I just wanted to check with you. You said that externally we can do evaluate, and I agree. Wherever it is not possible, ideal will be yes, the gold standard internal examination. But how do you report about this external examination? Just a brief idea to get some insight on.
How do you report? So I know we used to believe that internal examination is the gold standard, but more and more we're moving away from it because the gold standard is what works for the patient, right? I am finding myself increasingly not doing internal exams unless I really need them, because what we understand in sexual health is the more you can empower, because it's such a private issue, the more you can empower the patient, the higher the success rate. And they feel very confident about, oh, I diagnosed this for myself and I can help myself. Because a lot of times these people need more confidence in their own bodies. Because if you understand the psychology with sexual dysfunction, people start to have low self-esteem because they can't talk about these things. So one of the things we need to be careful with is, as a clinician, I don't want to put my finger in a vagina and tell them 50 things that are wrong with their muscles, because these are women that already believe they're broken and there are things wrong with them. So we're moving more and more away from internal exam. As far as how to report on external exams, we have external observation skills that can tell us if a muscle is working or not working, right?
Exactly. Yes.
So external palpation is very powerful. External self-palpation is very powerful. And really the bottom line is, I don't really care what their score on, that 1 to 5 scale is. If they're functionally getting what they want, I don't really care if they're 3 on 5 or 2 on 5, right? So it comes down to what your purpose is. Of course, if I'm writing a research article, yes, I need to do all the gold standard things, right? But on a clinical situation, not really. In fact, I try to move people away from internal exam because these people have trauma. A lot of times I have patients opting for telehealth option, even though I'm in clinic. That's because they want to avoid internal exam. They just don't know how to say that. Like if you're in a doctor's office, you don't feel like you have the autonomy to say, I don't want that. And even physios don't give people that option. We feel like, well, I'm the doctor, so I'm telling you, you need an internal exam. That's not true.
Post-menopause, there might be so much of a dryness. There can be so much of a discomfort. And elderly women really don't feel, very comfortable doing this examination. So sometimes they don't come for a follow-up. If it says, I want to do an insulin, they won't come. They will think this is going to be more troublesome. Yeah.
Exactly. Giving them the option is important. And I feel like by proposing ourselves as pelvic physios do internal vaginal therapy, half of the people already kind of said, yep, not going to do it. Sorry. So I feel like we're limiting ourselves even more by, there are already barriers. We don't need to increase the barriers, right? Especially when the effectiveness is not compromised.
Right. So the last month, if externally we are doing, and how to, teach relaxation or any modalities do you choose when we are not doing anything internal? So any of other modalities, the dilators and everything, if we are not going to do, so any other electrotherapy modality you have come across which can work, or the therapy, which is again going to cause some stress? So yeah, that's the last question from my side.
Yeah. Externally, you look at the global picture, right? So if somebody has like hip or lower back issues, we know that hip rotators attach to the pelvic fascia. So working on the hip and other mobility can improve pelvic floor mobility. That's one for relaxation, because a lot of times people who have tight pelvic floor have tight hip adductors and hip external rotators. So we know as a musculoskeletal physio how to get to those, right? That is one. Second, externally, there are so many releases for pelvic floor muscle, and you might know more than I do from the yoga angle. There are so many things in yoga that address pelvic floor and breathing and external releases with a foam roller, a tennis ball, and whatnot. Third is self-internal releases. The patient with a finger or with a Thera wand can do a lot of self-internal releases. And I try to keep electrotherapy for my kiddos. Like sometimes I treat patients with constipation for little kids, and I use biofeedback for them because they're external anal electrodes. I'm not putting anything inside, and they play a game on the screen. So it's fun for them because it's really hard as a little kid to get pelvic floor PT. Or when a patient is just so cognitively impaired, they have no brain-body connection, right? And that is a very personal bias.
So biofeedback, you believe that biofeedback works, right? So biofeedback you look at, right?
I feel like feedback works, tactile feedback, mechanical feedback, or biofeedback. Biofeedback is my last resort because one of my clinical values is patient independence. If I teach them biofeedback, they're dependent on me. So I didn't help them, right? Like the whole point of physical therapy is making people independent. If we are hooking them up to machines. Right.
Yes. No, you're not. So if we do first assessment on that, and then they give the home program, and they would love to see exactly what has happened to them,
Yeah, so some people really love the objectives, yes.
The machines, but when they see that and they know that, oh, now where am I? I know that I've been better, but now I would like to see how many millivolts, microvolts, X number. So
yeah, you're right. That can be very motivating.
Yeah. We can take more questions, Mayur. That's from my side. So great talk. And the gist you brought in so much of the importance of knowing this health issues with pelvic floor. Yes.
Thank you, ma'am.
Thank you, Nilima, madam. Dr. Darshana, we have some few more questions. So one of the question is, what is the treatment for bladder pain syndrome in men and women?
It depends on what that person is having as a bladder pain syndrome. Generally, bladder pain syndrome would mean there is some sort of interstitial disease of the bladder, right? So let's go back to the anatomy and physiology for a minute. Bladder is a muscle. Detrusor is a smooth muscle. The inner lining of that bladder is what gets affected in a chronic bladder pain syndrome, right? So step one treatment is understanding the medical management of that, because unless that inflammation is under control, nothing is going to work. Step two, usually people with bladder pain syndrome has myofascial trigger points in pelvic muscles. So physical therapy treatment would be something that you would do for an overactive or painful pelvic floor. Third is lifestyle management. These people need to learn a lot of trigger foods, a lot of trigger situations that need to be kind of self-education around it so they can have lesser and lesser flare-ups. So there is this, again, three-prong approach of medical management, physical therapy management, and then life management.
Thank you. We have one more question. Like, what should be the clinical setup? Are there any particular guidelines for specifically examining the patients, like privacy or closed rooms? Any clinical setup?
I would think you would want to give them a privacy and closed room if you're doing a vaginal exam. Yes, I think there's only one requirement for a clinical setup: safety. The patient should feel safe. Safety doesn't always mean physical harm, but you are not going to talk about your vagina and your butthole if you feel like three people can hear you. So, be respectful of the language that you use, be respectful of the facial expressions that you have. If you start to say, does your vagina hurt? You're showing that you're shameful of saying the word vagina. So the patient is going to catch on to that, right? Patients are not stupid. They understand every bodily gesture that we do. So safety is important. Sometimes you can make a person feel safe in an open gym just by the way you talk to them. And sometimes you can be in a closed room in the privacy of you and the patient and make them feel horrible. So the setup is not as important as much as the relationship that you create with your patient. Obviously, given the nature of questions that you're going to ask, it's probably best that there's not a third person listening in, right?
Very true, very true. Maria ma'am, you please unmute yourself.
Thank you, Mayur. Thank you, Darshana and Nilima, madam. And absolutely amazing, right to the point, touching presentation. I wanted to ask two things. One is there any connection that you have seen that generally when they have penetration issues or post-sex, they also have issues with pooping and things like that? So is there any
Yes.
connect between that? And second
Yes.
is what I want to have a personal count on your this thing. I understand sexual health is, as we said, a lot of psychosocial issues and a lot of taboos that are associated, and people don't talk openly with it. So when I'm looking at the student forefront and we want them, to start approaching and doing so, what was the barrier that you broke? Basically, first, I mean, going from here, you've gone abroad, you've done these things, you've studied, and now you're going ahead with it. So for our students, what's a message that you would like to give, how to start developing a rapport into talking into social sexual health?
Yeah, thank you, ma'am. That's an excellent question. So I'm going to start with the first one. Constipation, very commonly associated with overactive pelvic floor. So usually constipation and vaginismus go hand in hand. If you remember the slide about nervous system involvement, when people have trauma, they need a way of controlling something. And the way brain will control stuff is constipate, because there's at least one thing you can control: bowel movements, right? So young children who have abusive homes, or parents that are hitting them or something, usually they have constipation. So as a young child who has constipation is more likely to grow up and develop overactive muscles and some of the issues that come with the overactive muscles, such as penetrative pain. So it's very common to find vaginismus or other penetrative pain associated with constipation. And that goes back to some of those social stigmas again. Women don't really talk about poop. Like, girls are not supposed to talk about if they poop today. right? Like girls don't poop, they just have unicorn glitter coming out of their butthole, right? So no women will complain about constipation, just like they won't complain about vaginismus. In Indian women, what I see is we have created this myth. This is a cultural myth that nothing should go inside the vagina, otherwise you're not a virgin. First of all, virginity is not a medical concept. Virginity is a social construct that we have created to control women. And Bollywood has kind of uplifted it because, God forbid, something goes inside the vagina, the entire family and the village is destroyed. And of course, there is so many layers to it. But because of those barriers, women don't use tampons, or they don't go to gynecologists to get a gynecological exam. So a lot of times Indian women get diagnosed with vaginismus 1 year after they have been married and they're turning 30 and wanting a baby. And a lot of the other cultures, these problems get diagnosed much sooner because girls try to use tampons as a menstrual product and know that it is something's wrong, it hurts, and they get treatment sooner. So that's like we lose almost a decade of treatment for conservative cultures because we don't really know we have this problem, right? So your second question was how to break this barrier. It has been such an interesting journey because all the things that I'm pointing out, I grew up in it. I have all those barriers. I don't think if I was in India sitting in my living room right now, I would be giving this lecture with my family listening, right? So I get it. I am not judging anybody. I totally get it. And when I started this, I was that awkward kid who didn't ask about sex. I would just ask about bladder and bowel and just kind of move on, right? But I kind of fell into this because most of my patients had pelvic pain. So what I started doing was I started looking at the mirror and saying the word vagina, because it felt funny to say. I'd never said the word vagina. I had never said the word, does penetration hurt? Like I had not said the word penetration, right? So now it's nothing for me because I teach, so that word means nothing to me now anymore. But the first thing I did was I had to get over myself, because if I was uncomfortable, I was going to make people uncomfortable, right? Yes, I had to say the word vagina, but the person in front of me had their vagina hurting. So who had a bigger problem, me or them, right? So that's the way to look at it. But a very practical tip is you can have outcome index and forms. You can create a form to give out to your patient. Do you have accidental leakage when you jump? Do you have pain with sexual intimacy? You don't have to use words that you don't feel comfortable with. Do you have pain when you have relations with your partner? There's no word sex, no vagina, right? If the person said yes, that's your gateway. I see that you have said you have pain with penetration. Is it okay if I ask you more questions about it? Because consent is important. It's important that the person says, yes, you can ask me. Because sometimes the person says, yes, but that's not really important. I don't want to talk about it. So, okay, if that function is not important to you, then it's not important to me. And I have made my own share of mistakes. I would see an older woman and just not ask about sexual function because I assumed you're too old for sex. That was my bias. That was my assumption. And that was my mistake. And I'm trying to do better now, so you live and you learn. If you're uncomfortable with the words, use the forms, right? And if you want to be a pelvic health PT, eventually you're not going to be uncomfortable with these words.
Thank you. Thank you so much. I'm sure these tips are going to help, for our younger students when we are training them in women's health, to at least begin talking about the concept of sexual health and go deeper and delve deeper into. Thank you so much, Darshana.
You're welcome, ma'am.
I think we have a few more questions, Darshana.
Sure.
Any questioners used patient-related outcome measures separately for men and women? So there is a question that, are there any specific questionnaires which can be useful for a patient-related outcome measures? Maybe separate for men and women.
Yeah. Yes. So, chronic prostatitis questionnaire is for, I can put a link in here. Give me 1 second. Can you see my PowerPoint?
Yes.
These are your questionnaires. Take a screenshot.
Okay. Thank you.
Yeah, and once you check out those questionnaires, you'll know which one is for men, which one is for women.
Sure.
Yeah.
I think with that, we have come to the end of question answer sections also. There are no more questions
Awesome.
we can see. So, Maria ma'am, anything that you would like to say?
No.
Yeah.
I'm just too grateful to her and
Yeah.
Nilima madam both.
Thank you, ma'am.
So, Darshana, very thank you on behalf of Mumbai branch of Indian Association of Physiotherapy for accepting our invitation. We know that it's a very odd hours that you're working for us here. So thank you once again. I'm sure that therapists, there are many students who have listened to this presentation, and it will be insightful for them to enter into this practice. And we would have some more therapists who will take it ahead to the next level. So thank you for generating that interest in this area. We would also like
before everybody leaves, no, Mayur, just one thing, people can put their videos on for a quick photo click because we are all online.
Yes. Can we request everybody to put your video on if it is comfortable at your end?
If Moinesh can help us with the photo clicks, so everybody, whoever is on the laptop will be able to take it. Yeah. Done. Just let us know when it's done. Who's clicking?
Moinish, can you click the picture?
Because on the laptop, everybody's will come. Phone, I will not be able to do it.
1 minute, ma'am. I'm also doing simultaneously.
Yeah.
Okay, let everybody come
Really
on.
great to see
There are people still switching on
many
the
senior therapists are here today and attending this section.
Okay, let me know when ready.
I think you can take the picture, Moinish.
Okay.
Yeah, everybody may not be comfortable to build a video.
Yeah, done.
Thank you, Moinesh.
Thank you.
Thank you, everyone who's joined us today. Thank you so much. Yeah,
like to
Yes,
thank
thank you for
Dr.
spending a Sunday morning with us. Thank you.
We would like to thank Dr. Nilima Bedekar ma'am for accepting our request as the chairperson and chairing the whole session and giving her inputs also. So thank you, madam, once again on behalf of Mumbai branch of Indian Association. Thank you. We would like to thank Dr. Maria Jayanandani ma'am, who is a guiding force in all these educational series which we comes up with. Also, all the EC members who have been contributing to the success of this event. We would also like to thank Mr. Moinish Patil, who is our technical team support. Without his support, I don't think we would have been able to reach anybody on this pandemic situation. So thank you, Moinish, for all the technical support in the background. And last but not the least, we thank all the participants who have attended this session. I'm sure it will be beneficial for all of you to practice in the pelvic floor rehabilitation area. So thank you one and all for joining today and wish you all the best for the future.
Big thank you to Mayur, Ravindra and everyone, all the AC members. Thank you, Mayur, for being the master of the whole show. Thank you so much.
And one more before everybody leaves. The people who have attended in Zoom and registered, they will be getting their certificates. Please log on to our website, which is www.mbbiap.in, and use the name and the email ID which you use for registering for this particular webinar, and you can download your certificates from that. Okay, so this is the information for all people who have attended via Zoom and registered with us for this particular webinar. Thank you. Thank you, Mayur. It's been very good. Big thanks to you. We've breathing a sigh of relief because you had taken over this particular webinar on your shoulders.
Thank you. Thank
So
you. It's all under your guidance that I'm learning.
We are always there. Yeah, we work
Yes,
as a
yes.
team, and that's the big thing which supports Mumbai branch all the time. Thank you all seniors who have been as sincere and dedicated as usual, supporting Mumbai branch. We'll soon be seeing you all in our next webinar, or even the GB is planned in few months from now. Thank you. Thank you, Darshana. Thank you, Nilima ma'am. Thank you, Maria ma'am.
Bye. Have a good Sunday, all of you. Bye-bye.
Yes, ma'am. Bye.
Good night. Bye.
Good.
Thank you.
Good night.
Mohinesh, you can stop the recording. Huh? and live stream.
Sure.